TB preventive therapy for clients accessing DSD during COVID-19. For those of you who are new to the CQUIN webinar series, this is brought to you by ICAP at Columbia University and the CQUIN project, the International Treatment Preparedness Coalition, or ITPC, and the Differentiated Service Delivery Initiative of the IAS. My name is Dr. Anna Grimsrud. I'm from the IAS and I'm based in South Africa today, and I'm really honored and privileged to be the moderator of the webinar that's going to be an hour long and is going to be taking place in English. We have a full lineup today, and so I'm going to start very promptly and we'll be optimistic that more people will join us over the course of the next hour. So before I get into the detail of the content today, I wanted to highlight for those of you who don't know this already that this is a webinar series that's been taking place every Tuesday since the 31st of March at the same time. And if you click through on this hyperlink, once we circulate the slide deck, you'll be able to access all of the recordings and the slide decks in PDF, or you can go ahead and Google CQUIN ICAP right now and have access to those. So we want to encourage you to see all of the work that's come today, and just to remind our presenters that we are recording as well the session. So in terms of housekeeping, please feel free to ask questions of the panelists and presenters, and you can do that using the Q&A function. And then if you would like to, please go ahead and introduce yourself in the chat part of the Zoom webinar and select all participants and attendees so that everybody can see what you're chatting about. You are muted, and so later on, time permitted, if you would like to be unmuted, please raise your hand if you're an attendee, and we can support you to be unmuted. However, we'd like to encourage questions in the Q&A so that everybody can see the answers. So you might be asking why we're talking about TB preventive therapy, or TPT, and differentiated service delivery. And apologies for those of you who've seen a couple of these slides before, but we really want to make the case that we are seeing a simultaneous push to support the uptake of TB preventive therapy, while also scaling up differentiated ART delivery models. And so it really makes sense that we look and see how these two things can be done simultaneously and how they can support each other. So we note that there are similarities that the clients who are in differentiated ART delivery models are visiting health facilities less frequently often, and so they may be excluded from accessing TPT. But the DSD models for these clients might provide an opportunity to make sure that clients successfully do complete the TB preventive therapy that they need. To advocate for this to happen, we've been working to think about this over the last 6 months or so, but we are here today on this webinar to really think about what is happening now that we have this intersection between ART, TPT, and the COVID-19 pandemic. So what is really happening in the communities and the countries where we work? Some key questions that we want to think about when we're thinking about TPT and differentiated ART delivery is, should TPT completion be an eligibility criteria to join a DSD model? Can we align the duration of the TPT refill with the duration of the ART refill? And we'll see some great examples of that on the webinar today. And also, can the TPT refill duration be aligned for all members if someone is in a group model of getting their antiretroviral therapy treatment? So this was a supplement that we launched at the end of last year as the IAS DSD initiative that's on our guidance website, that's available in English and also available in French. But many of you have seen that before, and so like I said, today we want to focus on this intersection, DSD, TPT, but also COVID-19. And so we have a really exciting agenda for you today, and I'm really glad that we can bring in some of our TB colleagues and some of our colleagues from the pharmacy to understand what the reality is for people right now. So in terms of the lineup, we have 4 presentations, and then we're going to have some time for discussion and Q&A. So this is the lineup. First, we're going to hear from one of the real superstars in the TB community, Blasina Kumar, who's calling us today from India to talk about TB preventive therapy during COVID-19. And then we're going to have a series of shorter presentations from colleagues in the region. So we're going to hear from Kunga Morrison from the Ministry of Health in Zambia. We're going to hear from Joseph Kigundu, the National Technical Advisor for DSD in Uganda. And then we also are really happy to have someone with us from the PEPFAR team in Washington, D.C., who's going to talk about what the PEPFAR guidance is during this time and how that relates to TB, preventive therapy, to HIV, and to COVID. So we are really glad that you could all join us. And without further ado, I'm going to turn over to Blessy to lead us in our first presentation. Thanks very much, everyone.
Thank you very much for that introduction. And will someone be helping with the moving the slides, or
yes,
can I do it myself?
Yes, we will.
Okay.
I'm happy to help.
Okay, thank you so much. So yeah, I'm really, really glad to be invited and really honored to share something from the TB world about something that both HIV activists, TB activists should be working together with joint hands. So I'm going to share with you a little bit about TPT and then take us through some advocacy actions that we can do together as an affected community together, HIV and TB. Next slide, please. So we know that the isoniazid preventive therapy, or IPT, for people living with HIV was recommended way back in 1993. And we had WHO recommendations, UNAIDS adopting it, and other civil society, larger research organizations also adopting it. But unfortunately, the uptake has been quite low. Next slide, please. And then more recently, we have a new sort of guidance for newer options that don't just do with isoniazid, but other more effective drugs. And this is very recent. The conversation only started towards the end of 2018. 2019, we saw some early guidance that came out from WHO. And finally, in 2020, very early in January, we saw the consolidated guidelines on what is now called TB preventive therapy. And we have an operational handbook on TB for this. And we also have a mobile app. So this is a very recent development, though the conversations have been going on for about a year and a half on this. Next slide, please. So if you look at the Global TB Report of 2019, we see that the uptake has been quite disappointing of isoniazid preventive therapy. And there was only reporting from about 65 or 66 countries where the coverage was hardly 49%. And in most of the countries, if you take 16 high burden countries for TB and TB HIV, the coverage ranged somewhere between 10% of PLHIVs being covered and enrolled in a country like Indonesia with very high burden of both TB and HIV to 97% in the Russian Federation. So there was a huge range, but on the whole, the enrollment and uptake was very, very low, below 50%. And with the new UN TB high-level meeting, there has been a call that 30 million people should be enrolled on TB preventive therapy in the next 5 years. And of this, 6 million people living with HIV and 24 million are household contacts, 4 million children of that, and 20 million others. So we are looking at figures that are really huge, and unless and until there is rapid push and pressure, we are not going to reach, and our numbers are not going to go up to this many people being enrolled on TPT. And if you look at some of the countries, regions in Western Pacific, we know that isoniazid preventive therapy is being offered for PL-HIV as part of the baseline. But unfortunately, we have no clarity or data on whether it is being offered on a continuous manner and whether it is regular. Some countries in the region like Cambodia may be on track, but most of the countries, it may be accepted into the national strategic plans for TB, but there are a lot of issues. Then the new TB preventive therapy options are not being adopted and implemented. Drug availability is a huge issue. FTC is not easily available. South Africa, one of the countries that leads in these things, is still finalizing their TB preventive therapy guidelines, and they're going to include only 3-HP and 3-RH. I will explain this in a later slide. Thailand, it started IPT in the private hospitals and is looking at starting the new regimen as well. And hopefully in the next 1 year, there'll be a nationwide, it'll become an essential service across the country in the next year. Brazil, a country that really did well about 15 years ago with IPT, really slid back due to various issues. Rifampicin is not yet approved. The committee that has to approve the new diagnostic technologies and regimens has really is really delaying the approval of this. I know activists and our own partners and colleagues are sending another pressure letter this year. So unfortunately, the success of isoniazid preventive therapy has not kind of transferred onto TB preventive therapy with the newer drugs, which are much safer and much better. In a country like India, yes, in the TB National Strategic Plan, we have TB preventive therapy very much articulated, but it is not fully adopted, it's not implemented. The drug availability is a huge challenge. FTC is a huge challenge. It's not easily available, and the cost is a huge issue as well. Yeah, we can go to the next slide. So what is this, 3-HP and 1-HP that I was talking about? So this is the new options that WHO has given. They're much safer, they're much better, much shorter. So this is what we as a community should really be advocating for. So the first one is once weekly isoniazid plus rifampicin for 12 weeks. So that's only a total of 12 doses. This is for adults, adolescents, and children above the age of 2 years. Then you have the 1 month, which is a daily dose, that is 30 doses of the same thing, INH and rifampicin, for adolescents and children about 12 years of age. Now, both these regimens can also be given to PL-HIV. And then the next 3 are rifampicin-based regimens, which is either for 3 months with rifampicin and isoniazid. And this can be given to people who, PL-HIV, who are on rifampicin-friendly ART regimens, which the dolutegravir is one of those. And then you have an option of 6 months, 9 months, 36 months of INH, depending on the transmission settings, high TB transmission settings where you are. And then you have the daily rifampicin for 4 months for adults and children. So this is what is being offered, but what we should focus on is the 3-HP and 1-HP with rifampicin. Next slide, please. So during COVID, this was all before COVID. So what happened to some of the services? And this is not just very specifically for TPT, this is for TB, HIV, and TPT services as well. So GCTA, we did a very quick survey early on towards the end of March, and kind of tried to document the early challenges that countries were facing. And this is something that has come up from 18 different countries across the globe. Many of the countries were on lockdown. So there was no public transportation, which was the biggest challenge that people identified. So there was no way to access the drugs. ART centers were closed, TB dot centers were closed. There was no way to people to go and get the medications. So there was definitely a treatment disruption, and mainly for some of the most vulnerable groups. And then availability of drugs, if you did manage to actually go get to the center, there were no drugs available. And also a lot of health personnel were being diverted to combat COVID-19. So ART centers, TB services were all left with really no health staff to look after the people. And we have seen the repercussions of that. And then, of course, things like nutrition counseling really fell off the radar. So this is what was happening during the severe lockdown. I think most of the countries are slowly coming out from that, and a lot of advocacy has been done to address this. Next slide, please. So, as I said, some of the main challenges are we definitely saw a serious interruption of services because of lockdown. OPDs were closed, ART centers were closed, access to diagnosis, treatment, counseling, nutritional support really was huge. In fact, it was completely stopped. We also saw an increased stigma because people were in fear. There wasn't, COVID is a new virus. So there was conflicting information being given earlier on. People were scared. So fear really reinforced the stigma that already existed around HIV, TB. There was also a lot of reverse migration. I don't know how many of you have been following the news, but India has really been in the forefront of seeing the terrible status of people walking hundreds, some of them 1,000 kilometers over 2 weeks walking to get back home because they were all daily wage laborers, and the people who employed them stopped giving them any kind of salaries or any payments. So they were left with no shelter and no food. Many of them people living with HIV and people affected by TB. There's also a disruption in the supply chain. Generics took a huge hit. APIs were not easily available. And like I said, the focus completely went on to COVID. So even for advocacy, we've written letters to health ministers. We've reached out to the regional offices of WHO. We had a call as the Civil Society Task Force. But everybody is struggling. Many of the TB health staff have also been given the added responsibility of COVID. The same with HIV. And also with the funds. Any fund that is left over, even before we can think of how best we can use it to provide that added support, it was being diverted to COVID. I'm sure there are many more challenges, but generally taking from our survey and talking to people, these were the main areas that we found that services were really, really interrupted and challenges arose. Next slide, please. So now what is the way forward? Yes, advocacy is a huge thing, but something has come, some good has come out of this. There have also been opportunities that people have tried to piggyback on and kind of address the really vulnerable populations who are really struggling. Like I said, we've written in India, we've written to the health minister, we've written to the prime minister, really highlighting the issues and getting sign-ons by everyone to really move them to focus back on TB, on HIV, because otherwise all the gains and hard work that has gone in the last few years, we really stand in danger of losing that. We made our results available to WHO headquarters in Geneva and Stop TB, and immediately guidance documents went out to the national programs on how they should continue to focus and what they should be doing. Stop TB Partnership also commissioned a modeling which really showed that in the next 1 year, we really stand in danger of losing thousands, tens of thousands of people to TB and to HIV. So these are really, scary scenarios, and we need to really address this, keep working together to advocate. But coming more generally to TPT, we also have a huge role and responsibility in ensuring that TPT is rolled out. So when we're thinking of TPT, we need to really think about when, where, who, what. For TB screening, for TB preventive therapy initiation, for how are they going to be refilled, what is the sort of adherence support, and how do we ensure a successful completion of TB preventive therapy. Next slide, please. So just to give you an example from Zimbabwe, very good model, creating demand through community sensitization, identifying gaps through community monitoring, and establishing and strengthening the support mechanisms for uptake of TPT and its adherence. Very important. I think it's a great model, very much part of the community. We need to imbibe the whole TPT into the differentiated service delivery model. Next slide, please. So, we need to start with understanding that everyone has a right to access the highest available standard for TB prevention. Unfortunately, the IPT only era is over. We need to look at short course regimens, either based on rifampicin or rifampicin, because we know that they are easier to complete, they have less liver toxicity, and we have seen successful completion in many of the studies that have been done and in a wide range of settings. So we really have no more excuses not to use the rifampicin-based TB preventive therapy, especially the 3-month isoniazid and rifampicin once weekly, which is just 12 doses. Next slide, please. So if prevention is a public good, which I'm sure all of us think that it is, then tuberculosis preventive therapy regimens must also be considered public goods. So just to give an example, Sanofi, the manufacturer for rifampicin, it tried to patent the 3-HP fixed dose combination and started filing patents in nearly 70 countries. But we must understand that both these drugs were discovered many decades ago. And rifampicin is off patent and isoniazid was never patented. So, and 3-HP was mostly developed with public funding. So you cannot make a simple combination of these two drugs as innovation, and it doesn't deserve a patent. Luckily, the civil society has fought back. The Delhi Network of Positive People and one of our activists, Ganesh, filed a pre-grant patent oppositions in India, and then our activist colleagues followed soon after in Thailand. So now civil society is actually calling on Sanofi to withdraw their patent application and abandon their patents were already granted. So this really needs a combined effort for all of us to come together and really join hands to push for something that is easy to administer, easy to take, and has better results for colleagues all around the globe. Next slide, please. So I just want to acknowledge a few people. Avinash from WHO in Geneva, my dear colleague and friend Mike from TAG. TAG has also put out the activist guideline guide for rifampicin. It's great documents. Also, GCTA has a brochure for community on how to protect ourselves from TB. And of course, the WHO Civil Society Task Force, who also gave information of their countries and regions for this. Next slide, please. So with that, I say a big thank you for having me on this, and happy to take any questions. Thank you very much.
Thank you so much, Felicity. It was really amazing to get the total crash course on the history of where we've come from and where we are today in terms of IPT, TPT. So thank you so much. And please do feel free to ask her questions in the Q&A, and for the panelists to check out some of the answered questions where we'd also love to weigh in. So I'm going to transition now and hand over to Morten, who's going to give us a brief insight into how things are going at the moment in Zambia. Thanks very much, Morten. I'm just going to make sure you're unmuted. There you go.
Thank you very much, Anna, and good afternoon, everyone. So it's just a brief presentation on TPT SAGE sites in Zambia, and specifically looking at TPT and how we're aligning that with ART dispensation. Next slide. Yeah, so my focus will be mainly to look at our experience before COVID-19, and also what we've seen during the COVID-19 pandemic. So before the COVID-19, we were conducting TPT in all the ART facilities across the country. But our concentration was in the SAGE sites. So these are sites which we've selected, and we are more or less implementing TPT with specific targets which have to be met. So in short, there is more activity in terms of ensuring that a lot of patients are initiated on TPT with support from our partners and other stakeholders on the ground. So our plan was to satisfy these facilities, and once they are satisfied, we move to another round of selection of facilities. We meet the target, and again we move just like that. And the reason we did that was mainly because of stock availability. As from the previous presenter, it's been a challenge to have adequate stocks of isoniazid and other TPT commodities. So the response was very good from the facilities, and as I mentioned, support was there, so implementation wasn't a challenge, so to speak. So at the facility level, we used to have appointments for refills, and usually it was 1 to 3 months, depending on the patient, and also depending on other factors such as availability of drugs, stability of the patient, and as could be judged by healthcare workers who are attending to the patients. So we noticed that numbers of initiations were going up, and I think that we're on course to reach our targets in those facilities. Also, just to mention that we had commodities that were already ordered under Global Funds and USAID, and expected delivery dates were confirmed. Next slide. So this slide, I want now to highlight what we saw after COVID-19. So when COVID came, of course, there were these guidelines which were given across the country to make sure that we observe the regulations which were given by Ministry of Health. However, guidance was still given to the frontline healthcare workers, especially those who were attending to ART patients and TB patients, that TPT still needed to continue to the persons at risk of TB during the COVID-19 response. And because of that, I think what the program thought was necessary was to make sure that we aligned the ART dispensation with the TPT prescription. So in short, what that meant was that if a patient is being given 6 months of ARVs, then and they qualify for TPT, they are also supposed to be given TPT for 6 months. So if a patient has taken 1 month, meaning they've remained with 5 months of TPT, at the time they are coming, they have to be given 5 months. So it shouldn't be like you start giving them 1 month, 1 month. When they come at this point, make sure that you give them enough to complete a course of 6 months. So we also guided that only TPT SAGE sites should continue to recruit new patients on TPT. The rest we thought needed to focus on TPT completion for patients already on TPT. I think this we did because of what we observed from our stock availability at the time. I'm going to highlight this as we move forward. Next slide. Yeah, so in terms of numbers, so this is what we've observed over time. So as we can see, this graph is showing the numbers of initiation from February to April. And around March, mid-March, that is when we had the issuance of regulations for COVID-19 pandemic. So as you can see, I highlighted that we started seeing an increase in the number of cases, and we were, going up, as you can see, from 549, and we were going up, and our peak was around 3,200, thereabout, almost 3,300. But then we've observed a decline from that, and our numbers have been going down. So this is an observation we've made over time, and it's expected because obviously some of the patients may be shunning to go to the facilities, and obviously there's more attention being paid to COVID-19 as opposed to other disease areas, and also the fact that we are giving guidance for our staff to focus more on completion as opposed to initiation. So you can see why this is going down. But also, this could also be attributed to the availability of commodities, because giving a directive of starting to issue 6 months means that you are supposed to have a lot of stock for you to actually ensure that a lot of patients are supplied with commodities. So this is an observation that we made in general. We thought that we could have seen more numbers, but at one point, and that point coincides with the time when the regulations were issued, we see a decline in the numbers of cases. We can go to the next slide. Yeah, so what has been the key challenges? So one, physical distancing measures and the national quarantine measures have been seen to be interrupting treatment support. And as I highlighted, more focus on COVID-19 and less attention on other disease areas, including TPT. And it's expected that healthcare workers may be fearing to attending to patients. Also, patients would fear to present to the facility in fear of COVID-19. Now, giving 6 months of supplies to patients entails stockpiling of TPT commodities, and you must be assured of enough commodities for you to initiate a certain number of patients. Then you also have M&E related issues, obviously reporting, quality of reports, late reporting and so on. That may also have been a challenge. Then we've also seen some procurement and supply chain related challenges. Just go to the next slide. So we received communication from GDF. So most of the TPT commodities that we procure under global funds, they come through GDF. If you look at the communication here, they were saying at this moment in time, we're experiencing reduced manufacturing capacity by our suppliers due to the lockdown situation in the countries where medicines are manufactured. at the same time, we are facing disruptions in flight operations caused by delays and the cancellation of flights due to COVID-19 related control measures at origin and destination countries. So they said the accumulation of these bottlenecks leading to overall delays in the supply chain. So at a country level, if I receive such information, I have to start devising mechanisms of how do I manage the patients that I have, this is the commodities that I have, because that is like, even if you have expected delivery dates confirmed, there's still a possibility that there can be delays based on this communication. And then further, they said, lastly, we may also ask you to accommodate some flexibilities. So meaning they'll be splitting shipments for partial deliveries and so on. So what that means is that you are not guaranteed as in when exactly the commodities will come and how much of what you've ordered will come at what time. So that made us start thinking of how we can move as a country. So we thought just focusing on SAGE sites was the best way to go. And then for other facilities, we thought they should just focus on completion. So in short, they shouldn't initiate, they should just focus on ensuring that those patients who are already on treatment are given enough to complete, because we didn't want to have a lot of initiations and in the long run, we have interruptions of supplies leading to having a huge number of clients not completing treatment. Next slide. Steps. We feel with the challenges that we've seen, we still have to continue providing TPT while responding to COVID-19. And we also feel we should continue to offer support to the TPT SAGE sites by providing adequate stocks to meet their targets. All patients on TPT to be given enough supplies to complete the course. And we also feel we should continue giving support to our patients in terms of information, whether that be through phone and so on, so that at least they are supported as they are at home taking their medication. The other thing is that from the TB side, we are taking advantage of a platform we've created, the so-called TB Situation Room, whose overall aim is to monitor and spur the TB response amid the COVID-19 pandemic. And one of the indicators that we are following up is that of TPT coverage, because we feel that this for us is quite key. And we've also continued following up with procurements with that negative message or communication, but we still feel our commodities will come. So I think it's a matter of pushing, and will be provided with medication and continue ensuring that our commodities come and our patients access our TPT commodities. So thank you very much.
Great, thank you so much, Morten. And just again, to those of you who are attendees, it's some really great questions coming in the Q&A. And also now that Morten will be able to turn his attention to questions, just to note that we're privileged to have him as a pharmacist on the webinar today. So you may want to ask him specific pharmacy related questions. So now over to Dr. Josen Kugundu from Uganda, who's going to talk about the Ugandan experience. Go ahead, Dr. Josen. I believe you are unmuted, or go ahead and unmute yourself. Thanks very much. Okay,
thanks, Anne. And good afternoon and morning to everyone. I just want to share our experience. Next slide. Before COVID, a number of things were done, but I wanted to highlight that the regimen, if you look at the earlier presentation we had, the very first presentation, for Uganda's case, we have taken up 2 of these regimens. That is 6H, which is daily isoniazid for 6 months. And we have also the combined, which is Q-tip for the 6 months. And then we also have the 3HP, where we have the weekly isoniazid with rifampicin for 3 months. Now this, the 3HP is at a few facilities. These are the regional referral hospitals, but we plan to scale this up. Our eligibility is ideally all people living with HIV above 1 year with no signs and symptoms of TB. And then for those who are HIV positive, children below 5 years who have a history of TB contact, again, who have no signs and symptoms of TB. And this is irrespective of their previous TPT for those below 5 years. The next. In Uganda, we have ensured that TPT is integrated in all DSD models and approaches. And this we provided guidance, one of them being TPT being initiated by a clinician regardless of which approach. In Uganda, we have 5 DSD approaches, and TPT is initiated at the facility for all recipients of care receiving in facility-based individual management, the facility-based groups, a fast track, and community client-led at delivery. Now, these continuously have contact with the facility, so initiation happens at the facility. But for the community drug distribution points, here we take the services in the community, and therefore the clinicians actually initiate TPT while in the community, and they are monitored from there. The other thing was to emphasize patient education about side effects and when to return. And of course, just like Zambia, aligning TPT and at refills. That was very, very important. Before COVID, there was a bit of a restriction that you give the same refill, but when you're initiating, you give 1 month refill for both ART and TPT to give room for a review 1 month after initiation. For clinical monitoring, TPT is done at every opportunity of getting a clinical encounter, regardless where it is. And we gave detailed standard operating procedures of how to provide IPT in the context of DSD in the various models. And these standard operating procedures were distributed. Next. Just to show you some kind of quick data that we had for TPT in DSD models. We have 4 models. The first is the conventional, which we call the facility-based individual. And then facility-based groups, fast-track drug refill, CDDP, and CLADs. Out of data received from about 822 facilities, we had about, on ART, about 7,205, 725,000 on ART. Out of these, a total of 14 by the end of March were actually active on TPT, and the proportion of those on TPT varied. The highest was in FBIM, which was about 17%, and the lowest was in CDDP. FBG was about 15%, and CDDP was about 8%. But this is just to show a mix that at end of March, we had about 14% of our recipients of care are receiving from the data we have analyzed from the 822 facilities. The next slide. Now, we didn't change a lot when COVID came in because the essential services were ideally allowed to continue, and TPT was among the essential services. The challenge is that with the coming of TPT, the frequency of visiting facilities, even for those who are unstable, was actually reduced. And one of them was to ensure that now we do align TPT to longer refills, even for those who are actually unstable. In the context of TPT, the TB program actually proposed that we could give 6 months refill for TPT, but because of the ARV stock challenges, we agreed to actually limit this to 3 months to ensure that we align it to at refills. But this was approved, that even at initiation, you could give 3 months of TPT refills or provide prescription. The other was to empower the recipients of care to know what their side effects are for TPT, the danger signs, but also when to return at the facility. Of course, with the coming of COVID, a lot of remote support was engineered with the various implementers, and this required that we make phone calls. You've initiated somebody, you've given refills, you give phone calls to. Because also the travel restrictions of COVID, it was agreed that you don't have to go and pick your ART and TPT refills from your usual facility or where you're registered. It was opened up that you could get your ART and TPT refills from the nearest facility, regardless whether you're registered there or not. And of course, because you want to ensure social distancing, some of our approaches or models were actually suspended. And one of them was the facility-based groups. These were suspended because you didn't want people to aggregate together. The next. So the challenges. One of the biggest challenge was the clinical monitoring. This, we ended up doing it many of the times remotely, okay, through phone calls. But as you know, there was need that we actually have the clinical encounters. But because of COVID, that reduced. Of course, there were worries. Before COVID, there were reports of life-threatening adverse events of isoniazid, and there was a need to ensure we closely monitor, looking at the liver function test. But this was not done, and that was a challenge of COVID. The other was documentation. Documentation of who has received TPT, much so for the people who end up visiting facilities where they are not registered. And of course, this led to an increased loss to follow-up, but we are very sure that even some who are actually accessing, because the parent facilities may not be informed about the person getting their refill, they will document it as a loss to follow-up. So those are some of the key challenges that we have experienced. And in conclusion, our next steps, one is we have a plan, a bigger plan that goes beyond TPT to assess the impact of COVID-19 on ART and TB service delivery across the country. This, we have tried to put in a request of funding to ensure that actually we understand what the impact is and for better planning for any future such events happening. And the other, and of course with thanks from CQUIN, we are conducting a study to understand factors associated with IPT completion among the recipients of care on ART aligned IPT aligned multi-month refills by the ESD models. So these are some of our next steps that we want to look at. Thank you very much. I believe that was my last. I want to acknowledge the team that input into this from Ministry of Health, Uganda.
Thanks very much, Dr. Josen, for giving us that quick look into what's happening in Uganda, both pre-COVID right now and your plans going forward. I'm sure that people may have some follow-up for you, and I understand that you have other commitments, so we'll be sure to follow up with you on email if that is the case. So last but not least, in terms of presentations, absolutely, we're very excited to have Teeb Al-Samari from the Office of the Global AIDS Coordinator, who's going to help us by selecting out just the snippets from the PEPFAR guidance that is updated every week, a couple times every week, on PEPFAR's approach to ensuring access to TBT for people living with HIV during COVID. Thanks very much. Go ahead.
Thanks so much, Anna, and thanks so much, everyone, for your call. I'll just try to kind of quickly go through, because a lot has been covered by the excellent presentations before. So next slide. So as you know, COVID, HIV, and TB pose, I think, what I call a triple threat. And obviously the concerns are not just the potential impact of COVID-19, but the secondary impacts on service delivery that we're already seeing happening for HIV patients and TB patients. And then I would add kind of one more thing, and that is I think the potential impact on healthcare workers that we need to be kind of aware of and kind of protect healthcare workers as we move forward. Next slide. So we see COVID-19 and TB among PLHIV. There are still a lot that is unknown. Both are respiratory diseases with diverse manifestations, and environmental factors and host factors and comorbidities impact the presentation and the severity of disease. But we still don't know a lot, and there's very limited data and information on the impact of latent or active TB on COVID-19 disease severity. And there is a lot of discussion right now around the potential protection from BCG that has to be investigated more thoroughly, and there are some clinical trials that are starting to enroll healthcare workers in several countries. Next slide. So the PEPFAR guidance in the setting of COVID has really, the main thing has been kind of really pushing forward on multi-month dispensing, accelerating and scaling up multi-month dispensing, both for ARVs, TB medications, and TPT, including for children. TPT remains a core HIV service. And so the recommendation was for newly initiating patients that they receive a full course of treatment of TPT, of INH or 3-HP if it's available, and for PLHIV who are already on treatment that they get their remaining course or have it aligned with their ARV medications and dispensations. We're also really encouraging adverse event monitoring being done via telephone, SMS, or electronically, but as Josen pointed out, there are some challenges related to how do you document that monitoring kind of moving forward. Next slide. So there's also expanding decentralized drug distribution, and this is just sort of outlines some of the modalities and some of the areas where that can be done. Next slide. Okay. And so just some of the, we don't have any formal kind of systematic data, but some of the impacts that we've already heard around TPT uptake related to COVID-19. Just in context, as of 2019, end of fiscal year 2019, we had nearly 3 million PLHIV complete TPT in PEPFAR countries. And we're really moving forward towards scale up, and our targets for COP20, which would be FY21, were for 8 million people to initiate TPT. And so COVID really has posed a lot of challenges for that. So far we've seen declines in case finding and patients presenting to facilities, TB programs that have diverted staff to COVID-19 response. Obviously decreased diagnoses related to TB, decreased scale up as we've seen in the presentations. Several countries have adopted multi-month dispensing, as we heard, and differentiated service delivery for TB or TPT. There are several countries that are experiencing potential stockouts that limit multi-month dispensing. And then some countries are discussing and sort of have not quite pivoted yet towards multi-month dispensing in TB, DSD, such as Ethiopia. Next slide. So Leslie alluded to some of the impacts on the supply chain. So some of what we've seen are kind of many HIV commodities with 1 month delay. ARV manufacturers were continuing to produce their formulations, including TLD and other ARVs. But some orders are being delayed by approximately 4 weeks. A lot of this is related to cargo, travel, and closed borders. And then there are some delays that are being experienced within countries because of road closures and decreased transportation within countries. But so far, we've heard that most orders of essential medicines, including TPT, are arriving on time, but with a range of some countries experiencing delays. 3HP has had some significant delays in shipments. Sanofi has had reduced capacity due to movement restrictions. Their manufacturing is based in Italy. And McLeod's the generic manufacturer for 3HP, which was hoping to kind of accelerate manufacturing of their generic rifapentine. We've had several issues with, they had delayed submission of their validation reports to the Global Fund. This was sort of not related to COVID, but complicated by COVID. Thankfully, those have been submitted at this point, so we're awaiting their review. And then there's an ERP2 approval of the FDC, requires pre-shipment testing. And again, that's something that we're waiting for. So we're hoping that we'll be able to kind of continue to move forward, because several countries had quite ambitious targets for 3HP, and we're really relying on that shipment. Next slide. And then we just kind of, that's wrap up. Just, this is a slide with several resources, including our PEPFAR guidance, the WHO technical guidance, and the Global Fund situation reports. And I'll pause there just to make sure we have enough time for questions. Thanks so much.
Thank you so much, Teeb, and thank you for everyone for staying on the line. And we are going to turn over now. I'm going to turn over now to my colleague, Helen Bygrave, to convene a little bit of a Q&A. I know she has at least one burning question for all of the panelists today. But just before you go, to remind you that these webinars happen every week, same time, and that all of the slides and information are available and will be uploaded from today later on. So please stay in touch. Over to you, Helen.
Hi, yes, not much time, but we'll try and just get a couple of questions in, and thanks to those attendees who've been posting questions. Two big kind of areas that really came up, thanks for those great presentations, was obviously, although willingness to increase duration of TPT supply clearly challenges both from international supply and in-country getting those drugs to the clinics, clearly significant challenges that we all need to address. But the question I have for the panelists, Morten, you mentioned, and in your slide clearly showing, a decrease in initiations, you said, which struck me, fear to attend by the healthcare workers and fear to present. And I was delighted to see the Dr. Kigunda talk about remote consultations, and that's something. Morten, I don't know if you have any experience or would like to comment on how that is being implemented, how healthcare workers are adapting to do that, and whether you are experiencing challenges in terms of monitoring side effects when giving these longer IPT supplies and doing this follow-up remotely. That's a question from Dr. Hervé in East Swatini. So I don't know, Morten, if you have any comments about how we move to this remote follow-up if we're giving longer longer TPT supplies.
Okay, thank you very much. So so far the longer multi-month prescription of TPT has just been there for, I can say, for just about a month. Because initially it was business as usual, 1 month and so on and so forth. But the observation so far is that we haven't seen any difference in terms of adverse effects between those that have been given for 6 months and those who are given for less months. In terms of monitoring, one of the innovations we have is that of giving the patients as much information as possible, including their contact details. Should they have problems, they can call healthcare workers so that they are assisted with adequate information on what they are supposed to do. But of course, they are also told what is expected and when these side effects would come. In most cases, it's the first 2 weeks that we see the challenges of side effects. And so far, we haven't seen challenges. We haven't reported serious adverse events that can warrant, a patient being stopped medication. So I can say so far, so good. What we've just made sure is to make sure that we have adequate information provided, and that we are in contact with them should anything happen. And the DSD model on ART has been going on very well. The 6-month prescription of ARVs, and since we are just following SOT, we are just ensuring that we provide more information to make sure that our clients don't start doubting the information that is being given, and on the way they don't drop the TPT commodities. Thank you very much.
Thanks, Morten. That's really helpful, and I think that what you pressed there was this issue of ensuring treatment literacy, isn't it, and how important that is at any time, but particularly as we move through this difficult challenge of facing COVID. Just one last question, maybe this is for Blessing, because you talked about the different regimens. From a number of different angles, although this is a terrible challenge we're facing, it may provide us with some opportunities. And I just wanted to ask you, because certainly the speed of transitioning to less toxic, shorter regimens is quite different across different countries. Do you see this potentially as an opportunity to push from civil society towards shorter, less toxic regimens? Because this situation of seeing people needing to reduce frequency of visits, this is going to be with us for some time. So I just wanted to see whether you saw any opportunities here to push further to donors to move towards better regimens.
Yes, thank you very much, Anne. Yeah, definitely. I think we really need to look at whatever opportunities are available during COVID, addressing this huge pandemic, and see how we can leverage those opportunities to make it work for people living with HIV and for people affected by TB. And I think I'm really so encouraged to see in the chat section, Q&A section, that, it says that someone has mentioned that in Uganda, they're actually implementing the 3HP. Now, honestly, I wasn't aware of that. And so that's very encouraging. And I think this would really give us an opportunity to move away from just isoniazid-based preventive therapy and really move to better drugs. And programs have to really be pushed to do this. In some countries like India, it is the TB program that kind of handles this. But I know in some countries it's the AIDS program. So whichever it is, I think we really need to come together to push for better, what is better for our people, what is less toxic, what is easy to access in terms of easy to take, easy to cost, availability. I think we really need to keep these things in mind. Thank you.
Yeah. Thanks very much. I think we're pretty much out of time. I'll just hand over to Anna to wrap up. But thank you both to all the panelists and to your great questions today from the participants. Thanks a lot.
Thanks. And I'm just going to ask one more question of Teeb if she's still there. Just we've got a couple good questions here, and maybe you can answer both around what's happening regarding home deliveries and what cadre is carrying this out and whether or not they're paid and whether or not they have access to masks, as well as for programs that have mobile clinics. What are the challenges that are faced by these mobile clinics in terms of setting them up? So any insights you have on that, Teeb, at this time would be great. Otherwise, David and just everyone else still on the call, we will also summarize some answers to these questions along with the notes from the webinar today.
Yeah, thanks so much. So there is some home delivery happening, and it really varies even within countries. But kind of core to the recommendations and the guidance from PEPFAR is that the protection of healthcare workers and all healthcare workers is first and foremost. And so if they don't have appropriate PPE and protective equipment, that they maintain physical distancing if they don't. So all of that would be happening in line with those recommendations and whatever local recommendations and guidance exists. And then the second question regarding mobile clinics, I don't think I know what's happening related to mobile clinics. I know that, you know, programs are being very innovative and really trying to get medications to patients. But yeah, that is unknown at this time.
Great, thank you so much. Thank you to our panelists. Thank you to all of my colleagues who've supported the Q&A. And thank you to the attendees. As noted, these slides, the recording, and some answers from the Q&A will be posted in the next couple of days. And we really hope to see you join us again on the CQUIN DSD webinar series. And thanks again for your interest in this intersection between TB preventive therapy, differentiated service delivery, and COVID-19. Have a great day further. Bye.
Thank you. Bye-bye.